All right. Good morning, everybody, and welcome to the PowerTalk Informatics. Actually, our Department of Biomedical Informatics and Data Science, our new department, our PowerTalk seminar series. And happy Friday to everyone. And really happy to invite today's speaker and introduce him, Dr. Thomas Kannamplallil, Associate Professor of Anesthesiology at Washington University School of Medicine. He also has appointments in the Departments of Computer Science and Engineering, and also in the Institute for Informatics. His research interests are in an intersection of computer science, cognitive science, and clinical informatics, focused on developing and evaluating intelligent computational tools for improving clinical decision support and patient safety. Okay, they're having some microphone and camera problems. Okay, so additional roles, he's the associate editor for the Journal of Biomedical Informatics and also serves on ONC and PCORI technical expert panels on health information technology. He's currently funded by three ROIs, sorry, from the National Library of Medicine, the National Institute of Aging, and the Agency for Healthcare Research and Quality, AHRQ. And he was elected as a fellow of the American Medical Informatics Association, FAMIA, in 2021. I also know him from when he was in Chicago at UIC, and also we have shared background in WashU. And his talk is of great interest to everybody. It's a big topic right now, physician burnout. So using audit logs to measure physician workload, cognitive burden, and burnout. Dr. Kannampallil.
Thank you, Amy. I really appreciate that. Can everybody see my screen? Just wanted to make sure for the room and hear me. Okay, all right. So, today I'm going to talk about sort of a thread of my research that's started during at the beginning of COVID. So, I am primarily trained as a cognitive psychologist, and even though my title says Associate Professor of Anesthesiology and Computer Science, I'm neither an anesthesiologist or a computer scientist. I'm a clinical informaticist now, but in a prior life, I was a cognitive psychologist. I've worked with Vimla Patel for several years, sort of transitioned into this in-between role as a clinical informaticist over long periods of time. So as I was saying, we were sort of shut down in all of our studies, all of the studies that I was doing at the beginning of COVID. This is now 4 years ago, February 2020, March of 2020, and I was looking for other things to do. And we've always been interested in this large, sort of analyzing large volumes of data on user interaction logs. So I came across these files, identified these files of files in the Epic databases to look at audit logs. And then now 4 years hence, I spent probably about 50% of my time through funded and unfunded work really using audit logs. So with that, some financial disclosures. None of this is related to this work. Some of the funded research projects I will talk about a little bit, not a lot, but some of the work has been funded by some of these work. Like I said, my background is in sort of my training is in cognitive science and cognitive psychology. And sort of by chance, I got into clinical informatics, and I do a lot of things, but generally, these days, my research areas are sort of focused on patient safety related projects, specifically medication safety, clinical decision support application. And I do a lot of work in these days in my home department in perioperative outcomes, specifically prediction models on both intraoperative telemedicine, postoperative outcomes, lots of model implementation specifically in the perioperative world. I won't talk about that today. I'll specifically talk about sort of this broad spectrum of work that we've been doing on using audit logs to study clinician workload and burnout. So, as everybody knows, and this is sort of a hot topic at this point in terms of the role of EHRs in supporting clinical work. Almost 50% of clinician time is spent on EHR, and almost all clinical care processes pass through the EHR in terms of its documentation, review, or some sort of communication patterns. that happen. And as a result, the electronic health record has become a central point of almost all almost all clinical work documentation. So what does that mean? The sort of downstream implications of this is that it increases the clinical workload on the clinician because of the extra work that's potentially needed in order to manage the work activities. It increases the burden. Downstream, it has been described to increase burnout among clinicians because of the unnecessary and unwanted work. And more importantly, these days, the impact of all of these factors also contribute to physician turnover, and the large institutions such as the AMA has been describing that in an outpatient physician leaving practice costs the institution about $1 million in expenses over a 1-year period. So it's not only does it have implications for the individual clinician in terms of their wellness and well-being, it also affects institutions downstream. The ways to study, especially some of these things. So, for example, burnout. So some of these things have primarily depended on survey-based approaches. So, for example, the only metric that almost the universally used measure for assessing burnout is surveys. Like there's several versions of different types of surveys. For example, the Maslach burnout inventory is the most commonly used. There are other vanilla versions that have been developed from it, but essentially it requires some sort of user input. And if you look at workload and burden, it is essentially being studied using observational tools or self-reports. If you look at other downstream outcomes like patient safety outcomes, again, self-reports, medication errors are primarily reported through self-reports. As a result, what has happened generally is that almost all of the studies are small-scale studies, and the scalability of some of these methods that have been used is sometimes questionable. So this brought us to this idea of using audit logs, which are again a sort of a trail of clinician activities on the EHR, specifically as part of the ARRA and HIPAA compliance in 2010, all EHRs are supposed to have audit logs as a measure for security reasons. So essentially, it captures whenever a patient data is viewed, modified, or edited. It essentially, in a very simplistic terms, it audits. It tracks the audit on user actions. So basically, who performed what action on which patient's chart. So if you see this image on the right, which is it's completely de-identified. It's from a long time ago. You can see that there are a number of actions are basically performed and a set of events happen, and set of events that you can see as a metric name that occurs as a result of the actions that are performed. So essentially, this user logged in. Some things happen on this is again from an Epic audit log. So it was the physician then clicked a patient, then several things loaded at the same time. Then after a period of time, you can see that they clicked certain things, selected a patient, clicked a report, viewed the notes, moved to in-basket message, and appended a clinical note. So you can see sort of a trail of activities that happened over that short period of. Again, this is not a real patient. So so in a sense, these audit logs have been defined to be a sort of fingerprint of clinician work, although approximate, and also a fingerprint only of the EHR-based work. And there's been lots of papers, mostly descriptive studies, basically describing, differentiating between time spent on the EHR versus time spent with the patient. Most of this work has been situated around understanding, sort of aggregating the components of EHR-based work that people are performing. So, for example, documentation, review, reporting, responding to messages. And I also want to add, even to date, much of the work has been focused on outpatient related work. And what I'm going to talk mostly today is about inpatient, the use of these audit logs in inpatient work. Again, this sort of review, the editorial was from 2020, which sort of projected the potential uses of EHR audit logs for health services research. And I can tell you, based on a couple of systematic reviews that Adam Rule from Wisconsin published in the last couple of years, had about 100 papers published in informatics. So this is an expanding and widespread adoption area in terms of research and in terms of the research enterprise for using audit logs as a measure across the board. I'll pause for a second. I cannot see if there's any questions or not, or if there's anything that I'd like.
No, this is appreciate the background, and I happened to notice on that slide that you had that listed the different events happening, even though I don't know if that was a real patient or not. That just look how much was happening in just at 721, and
that's correct.
Before they even started to see any patients, probably, and it's just like that's just like how many things then, and you just add that up over the whole day. But also, can you go to the next slide? I want to. Oh, go ahead.
No, I just want to say, so this is essentially a colleague of mine who's an anesthesiologist basically opening up a chart for a patient who's going to have surgery. And this is the first 2 minutes of that process, right? A lot of these things also happen, they're auto-generated events when things load on the interface. So they are epic. Like, for example, the visit navigator template loaded. Storyboard view, these things automatically load when you select a patient. So some of these are automated events from Epic, others are not, like chart review notes tab selected. You're selecting the note tab, then you're actually viewing the note, things like that. Go ahead, Amy, you were going to ask.
Oh, well, that's just all the cognitive load. Also, that. So I just want to take a look at the slide you had with that graph that showed the different.
This one?
Oh, the one before that.
Oh, sorry.
Oh, that's okay. I was just, yeah. Just
this one.
Yeah, that one. Yeah, that's just so helpful to be able to see that and to see like in a big picture, like what days of the week and, times of day and things like that. So thank you. I look forward to, all these interesting things as you uncover the things that you found with these audit log.
Yep. So in general, what I talked to you about was what's stored as audits, but there are Epic UAB is still on Cerner, right?
Yes.
Yes. Okay. So I am going to talk mostly about Epic, but I can answer some questions about Cerner. But in general, both Cerner and Epic have their own summary stats from all of these at a physician level, and Epic uses what's called Signal. Cerner has what's called a Lights On framework and the Cerner Advanced platforms, which can be used to, for example, if you want to summarize at an individual physician level over a period of 30 days, they give these summaries, and you can use that to create summaries. The advantage, the advantage of the sort of aggregated audit logs in Signal or Advance is that it gives a per physician summary. You don't have to do any processing. You don't have to worry about what the events are, like in the raw event log that you saw. They do not use the same audit log framework. They have their own framework, and we can get into details about how this is how this is actually processed and stored, both in Millennium and Epic's Clarity tables. Happy to get into the weeds with respect to the database structures and things like that. In general, what I want to say with the audit, with the Signal and Advanced platforms is that it's really useful if you're looking for summary statistics with respect to at the physician level. It's easy to use. It's very limited. And there's absolutely no transparency among the from the vendors as to how these metrics are developed and measured, and they change over time. So it's really good for longitudinal. It's really good if you're looking at the individual little longitudinal measurements. If you're trying to do research with this, it can get challenging. But again, in contrast to that, the raw audit events, you can get large volumes. So our current volume is about 25 billion or so rows over a 5-year period, where WashU went to Epic in 2018. You can get the sequences of work. You can, but you need a significant amount of effort to translate this into meaningful metrics. And I can talk about this. We have our group has a GitHub page with all of the code that's into processing this data in order to create these metrics. There's a lot of approximations that need to be done, but there is a community of us, and there's a national research network that Julia Adler-Milstein runs out of UCSF, that we are all part of, where we share code, analysis, analytics. Again, this is still a burgeoning area of research and still lots to be figured out. So that's sort of the 10,000-foot view about what these are. But again, the question, like I said, in 2020, when we were starting this work, is what are we doing? And this was like sort of timely in the sense that the National Academy of Medicine came out with its report on how to solve burnout, and sort of their framework was what they call a system-based framework, where the clinical environment was moderating the sort of the work-related factors in the clinical environment and the individual factors together were potentially contributing to burnout and downstream outcomes. So what we tried to do was, what can we capture in terms of work-related events in sort of an unobtrusive fashion, right? Things about the patient, things about what happens in a specific work environment. We can also use audit logs to characterize EHR-related work activities, documentation, review, things like that, and potentially look at individual factors. I'm not going to talk today about those, but in theory, you could look at personal individual level factors that potentially affect work behavior. So what we try to do is essentially take this overall framework and to sort of project it within the construct of audit logs in order to study certain outcomes, specifically with respect to both burnout and errors. So our sort of conceptual structure paper is actually published a couple of years ago. So again, today I'm going to talk about several studies, but together the overarching idea is that how can we use raw audit events, and translate them into metrics related to both workload and cognitive load, and how can we use that to study both burnout and medication errors specifically. And I'm going to talk about a specific type of medication errors called wrong patient errors, which can be using retract and reorder, and I'll get to some of those things. I'll talk a little bit about the sort of the machine learning work that we did with trying to see if we can use these data sets, these streaming sequential data, in order to predict burnout. And just to preview the result, it really was not very successful, even though there is potential for that. So I'm going to get into some of the studies that we did. Any questions? All right. So the first study is we did was in order to measure cognitive load and to look at how cognitive load affected the overall workload and errors. So for this, we started with this idea of cognitive load for measuring cognitive load. So there's significant research in cognitive science, which has essentially said that attention switching between tasks increases the cognitive load associated. And as a result of the attention switching, so a lot of these studies were done using task switching scenarios. Basically, you ask people to count from 1 to 100, and then suddenly in between the tasks, they ask them to, count backwards from Z. Backwards all the way to A. So that switch between tasks increases what is shown in the research is that the switch between tasks increases the time on the immediately following task, and increases the potential for errors. So the reason for the increase in the time for the switch task is because it increases the cognitive load for people to switch between the tasks. This also increases the likelihood of errors in the immediate post-switch scenario. What we try to do was we try to look at attention switching and looked at whether the attention switching has impact on downstream effects related to efficiency in terms of like how long does it take to complete the task, and also related to does it increase the number of errors. So what we try to do was to come up with a metric related to attention switching. And specifically, we're looking at switching between patients in an uninterrupted sequence of actions in an audit log sequence. So if you look at this, there's a total of approximately 6 minutes for about 4 minutes and 21 seconds. This physician is on patient A, and then moved to patient B, and then works for about a minute and a little over a minute, and then there's a big gap between 6:36 and about 9 minutes, and we're assuming that the person walked away. We used a cutoff of 5 minutes based on lots of sensitivity analysis. So essentially what we measure here is that this attention switch, where they switch to another patient in an uninterrupted sequence of less than 5 minutes break between the sessions, we call it a patient switch. And then we assume the sort of hypothesis that switching between patients increases the sort of both work and the total time spent on the work and also errors. So again, the goal was to measure the relationship between attention switching, work efficiency, and errors in a subset that we looked at in the ICU. Total EHR, the outcomes were total EHR time and wrong patient error. And wrong patient error is wrong. I don't know if folks have heard about wrong patient error. A wrong patient error is a standardized metric that can be detected through this algorithm called retract and reorder. Essentially, Jason Edelman at New York Presbyterian came up with this metric and sort of validated it. Basically, if you make an order on a patient, cancel it retract it within the first 10 minutes, reorder on a new patient within the next 10 minutes, it has over an 80% positive predictive value of being a wrong patient error. Again, it's not perfect. The rate of wrong patient errors have been validated in a number of settings. For example, in EDs, it's about 100 per 100,000 orders. So it's small but not negligible. So again, that's the wrong patient error. So with the study, we ran this in 4 surgical ICUs at WashU, 18 million audit log events, 62,000 hours of EHR work. So you can see how quickly we can scale this in terms of the scale of the study. So you can see we had about 95 participants who worked for 1 whole year in the SICU, in the 4 SICUs that we did. Again, you can see that the physicians don't place a lot of orders in the ICU, so you can see very few, but among APPs. So just for context, I don't know how many folks have a clinical background or not, but generally the ICUs are manned by both physicians and advanced practice practitioners. APPs work almost like residents, except that they don't rotate through multiple units. They're in the same unit, as a result of which they're sort of permanent workers in those ICUs. Any questions? I know I went really fast, but.
There was a quick question in the chat. How do you measure burnout by the number of errors made by a user? You did mention previously that a lot of burnout studies use surveys. I don't know how you would assess burnout versus maybe you're looking more at things that might contribute to burnout.
Yeah, so I will get to burnout. But this study was not measuring burnout specifically. This is only measuring cognitive load. Just wanted to clarify. Does that?
Yeah, I think that addresses it. Plus, you're going to talk more about burnout later.
Yeah. Okay. I'll get to burnout. All right. So again, this was specifically looking at cognitive load and outcomes, really. So again, you can see some measures of work. Specifically, you can see that we created some metrics related to number of actions per day. So about 700 to between 700 and 1,000 actions between audit log actions that we use to measure. You can see these patterns. Well, this is normalized on a 6 to 12-hour day. Both attending and APPs had 12-hour shifts. This doesn't look at night and day, but you can see when they come in, there's a big jump and then it sort of goes down. But then again, there's sort of a peak towards the end before sign out. So again, sort of discriminant validity in terms of face validity in terms of like what sort of actions you would see. So I'm just going to jump straight to the results. We used fairly straightforward mixed effects models controlling for multiple user days within this. What we see in APPs, the increased rate of patient switching from 25th to the 75th percentile increased the total EHR time per day by about 17 minutes, 0.2 hours, or a 7% increase. Similarly, when we looked at the increased rate of switching in wrong patient errors, we found an increased rate of switching from the 25th to the 75th percentile, increased the risk of wrong patient errors by 28%. So again, it was, and again, there was no effect for attending physicians in either one of these conditions. So again, what we wanted to highlight is the role of attention switching, in this case, specifically patient switching as a metric for assessing cognitive load. And we've done in a number of studies and replicated this. And then it is being associated with increased EHR time, which shows decreased efficiency and potentially increased wrong patient errors. There's lots of limitations. We don't know the cost for the attention switching. It could just have been that it was a volitional switching. We also do not know all attention switching events. Only we know attention switching between patients. We do not know the attention. We cannot reliably measure the attention switching within a patient. We just published this, I think, last year, the British Journal of Anesthesia. So happy to talk more about this, but I want to move on to the studies of burnout with folks who are asking. So now, the sort of first study we did, was there can we measure cognitive load as a metric related to switching potentially, and sort of measure its association? Then the question really was, this is mostly towards creating a set of measures and metrics that we could potentially use. So, and then we wanted to do this bigger study with burnout. And the burnout study is sort of extending sort of the metrics that we developed in that. So I don't need to stress the importance of burnout in the modern clinical practice. 50% of practicing physicians are supposedly burned out, with 70% of trainees and medical students also being burned out at some point in their career, at some point in their work. So the measurement of burnout, as I said before, is super challenging. Primarily relies on survey data. Survey responses among physicians, especially, is very low. It's usually most burnout studies report about between 10 and 20% of response. Almost all studies are cross-sectional, meaning they measure at one point, and then say, hey, person's burned out. And by the time the results are published, it's much longer. So the questions about what to do with the findings you get with burnout from surveys is also up for debate in terms of what to do. So our sort of idea after we did these preliminary studies with respect to collecting data using audit logs and measuring them is, what if we could screen people for burnout using audit logs, right? So that was sort of the overarching question that we started with. Essentially, the idea we started with was a phenotyping of burnout, similar to what you've seen with, all of these wearable devices. So, for example, can you look at low-level features like, how much you walk and how much you who you interact with when you sleep and when you wake up, and how can you use that for measuring higher level markers and looking at clinical states such as depression and anxiety. And there's several studies using sort of wearable devices and phone mobile devices in order to measure. So our idea was essentially similar to that. Basically, if we can look at these low level features such as patterns of EHR use, can you use that to measure workload or cognitive load or burden or efficiency measures as sort of intermediate markers? Can we actually measure burnout? So that was essentially sort of our framework, sort of the conceptual framework we were looking at. And then the question was, what are sort of the workload features that we can look at? As I showed in the previous study, there's a number of measures that we can measure in terms of number of patients handled, total EHR time, after hours EHR time, how much time you spend in the inbox. When we did this study, we did not have secure messaging time. We can measure secure messaging or any sort of equivalent communication channels. Orders, how much time spent on notes, reviews. We can also, the advantage of these sort of longitudinal sequences is that you can use them to measure temporal patterns in the EHR in terms of click activities. You can measure features, these as features along the line. So again, that was the sort of the overarching plan with which we went. So we did a longitudinal study, 6 months. Again, this was a pilot study in preparation for a grant, the HRQ grant that I'm going to talk about. This was a pilot study. We did a 6-month study, primarily with trainees, because this was in the middle of COVID. I want to say 2021. Yeah. So what we did was every participant, we were 104 eligible participants, 75 agreed to participate. And what they had to do every month was complete a survey. I'm going to talk about the survey. It was a Stanford PFI, which is a shorter survey. It's a validated survey for burnout. They complete a survey every month, and that's all they do. It takes about 2 minutes, that survey, and they complete it for a period of 6 months. What you can see here is, as opposed to almost any study you would see with residents, our response rate was about 77%. Over a 6-month period. And there's lots of reasons I can talk about how we actually ran the study. And the simple answer to that question is instant gratification. The moment they finished their study, they got a $5 gift card, right? The moment. So we set up gift cards that were given to them at the beginning. 2 minutes it'll take. The response rate was amazing. Again, what they did was essentially completed the survey and gave us permission to use their audit logs for the previous 6 months. These surveys were also timed to their rotation sequences, so 28 days. So when they finished the rotation, they got this. So it was sort of attached to rotations. There was all sorts of complexities associated with it, specifically related to matching them to the specific rotation. Sometimes, matching was harder. Again, so 6 months, they gave us the audit logs and also the wrong patient errors during the period of time. So our primary outcome was the burnout score. And the secondary outcome, we looked at the wrong patient error during the same period of time. The PFI, this was, this was developed by some colleagues of ours who at Stanford, Mickey Trockle builders. They have a large consortium called a professional fulfillment, the Stanford Professional Fulfillment Index, where you can pay into where they can deliver surveys to your practicing faculty, and they create a consortium, all of that. But this specifically for the study, we were not part of the consortium, but it was done as part of an IRB approved study. Again, so we did, like I said, we had 104 trainees. They were only recruited from medicine, pediatrics, and anesthesiology, just for consistency. And like this for first year, they were interns, so their practice for all of the 3 were in similar medicine type of settings. What you can see here on the right, like these were the metrics that we measured from the audit log events, like the total EHR time per month, the average time after hours time, number of patients they handled, number of patients they did, the inbox time, and as some of you may or may not know, WashU is primarily an inpatient training. Most of the training programs are focused towards inpatient. There is some, but mostly inpatient. So there's very little inbox time. Number of order sessions. A lot of these measures got directly from our audit log. So what did we find? We found that what we found were a couple of things. That burnout score, like you can see, this is all the like 74, 77 participants. You can see the burnout just went up and down, right? Like it changed over time and over the 6 surveys. But there were some patterns, right? Like, so you can see this example, so you can see this person's, participant's burnout score in red, which goes up and down, but it also is associated with, like, where they were working. When they were in clinic, it was down. And also the other aspects, number of patients, it was also associated with the number of patients that they were, average number of patients per day they were seeing. It was also sort of correlated with the total EHR time. So again, what was interesting in this, and again, to the best of our knowledge, there are very few short-term longitudinal studies of burnout, making it difficult to see, right? Like how burnout changes over time. So one of the sort of, before we started the full-fledged statistical analysis, what was interesting was that like it is surprisingly elastic and people go up and down and it's harder to measure, and it has implications on what I'm going to talk about later. So again, I'm not going to get into the methods of statistical analysis. We used another multivariable mixed effects model. What we found was that burnout was associated with the total EHR time, how much you worked, how much time you spend in review of charts, potentially related to patient complexity or efficiency with which they're managed. But we did not find, there were very few retract and reorder errors during the 6-month period with the cohort. So we did not find an association between workload and burnout and wrong patient errors. So again, so there's lots of things that we can say, but a total DHR time, patient load, and chart review time were associated with burnout. There's potentially lots of limitations of the study. Primarily, this was based on interns with large fluctuations. But the biggest sort of insight that we drew from this is burnout is surprisingly elastic. People recover fast, but get back into those sort of modes. You can read that paper. This was in Journal of General Internal Medicine, I want to say a year and a half ago. But the more important thing was this was a pilot study for our currently ongoing HRQ-R1, which is specifically looking at these sort of longitudinal measures and predicting burnout from those. I'll pause for a second before I get into the other.
There's a comment from Jim Semino. Liz Chen, now Brown, looked at specific clinical data to show that after looking at a liver ultrasound report, clinicians would tend to look at liver function lab tests. That's kind of funny. That's maybe that something sticks in your mind, and then you're thinking, oh, I better check that. Also, just a quick comment that, and you might be addressing this later, great study, and look forward to seeing more come out of that with studying all those different factors and how the fluctuation and everything. I'm kind of wondering that, I wonder how that would look for, say, people in outpatient where,
Yep.
high volume and everything. And then also people who are later in their career, maybe who have like kids and things. I noticed only 5% of people who had kids. And so I thought, because that's a big contributor.
Those are trainees, right?
Right. They're young and healthy and bright-eyed.
Yes. Hi, Jim.
I'm trying to make a comment, but our setup here is horrible, so I'll try to put it in the chat.
Should I? I'll continue, and then I want to respond to what Jim said about relationship between actions, right? Like in terms of sequences, right? Right, when all of what I'm going to talk today is only about like looking at these bigger level measures like cognitive load or burnout. But I have a PhD student who's basically looking at work sequences. Are there patterns in how people work, right? So what he did was essentially took about 1,000 users, not 1,000, 500 users, and build individual level language models and computed and the entropy of those action sequences, essentially to see, do people work exactly the same over a period of time, right? Like assuming that patients are similar, they're working in the ICU in the same unit, right? And what you find is that, again, this is super preliminary, is that there are certain actions that are sort of unexpected in a sequence, right? Like a secure messaging. And then, basically that actually changes their workflow in terms of expected actions, right? So again, this is a ripe area for studying at scale behavioral patterns. Again, can be associated to known outcomes. That's much harder. But again, that's potentially the direction here. All right, I'll keep going. So this sort of relationship that we found from the previous study, basically saying that, you know, audit logs or EHR actions, EHR actions can measure total EHR time, and that's associated with burnout, which potentially shows the potential for maybe you can use these audit logs to predict outcomes such as burnout, right? Like, so it was a small sample, but like 528 individual people in the 528 surveys from the participants in the survey, and so we built a nested cross-validation based model that try to do some simple models at first. So essentially look at specific features related to workload. We combined both the workload specific features and temporal features separately first, and then put it both together in a model. And unfortunately, what you see here is that the models don't work very well. And there's lots of reasons, and I'll get into the reasons why these models didn't work. But what you see is that even if you put all of those features associated with workload, like total time, factors related to, number of patients seen, a number of orders put in, things like that, and also the temporal characteristics into these machine learning models, they performed really, really poorly, slightly better than chance in predicting the outcome. But, and this was further validated by the fact that if you use just the first survey score, the model predicts the outcome pretty well, better than using any of the factors. So what does this really mean? It really means, and we wrote this paper in JBI trying to describe why this was happening, primarily associated, and I'll get to some of the details of why it potentially doesn't work. And one of the reasons is that of the elasticity that I was talking to earlier. And then we got into trying to see if we can build these, maybe this is sort of done in parallel, to build these sort of deep learning model and to try to take this sequence of actions and convert them into broader chunks. So for example, we use this sort of NLP type of the word-to-vec type of approach, where we take a set of actions where you think of these action as a word and convert them into like set of actions being in part of a paragraph, that being a shift, and then taking that, combining that again into at a month level, where we have an index of the burnout, which is sort of reflective of an article. So essentially, the skip-gram approach that most of you are probably familiar with, we were essentially predicting the context of a given action within given a target set of actions using like sort of the raw sequences. Again, I'm not going to go in and get in the details. This was done by one of our CS PhD students. We basically took and we built a hierarchical temporal convolutional network, essentially sort of hierarchy at the level of the individual actions, combining them, and then building these, putting them into an LSTM and trying to predict the outcome. The biggest challenge in these sort of models was that it was at a day level, a person had about 2,000 events, between 1,500 and 2,000 events, and it was hard to put into a recurrent neural net. So there were some challenges into building this. But the sort of takeaway point is that those models, as you would expect, did not work any better. The best performing model still had a AUROC of slightly better than chance. But what and this was incidentally, this was one of the best papers at KDD in 2022, I believe, in the applied track. So again, the topic is important, but again, the findings from this are not super exciting. And there's several reasons for potentially why the models did not work. And one of the most important is that the models really got confused, because you can see the same person who essentially the fact that the elasticity of burnout created confusion in these models, and you could not predict whether a person who worked 80 hours could be burned out. Similarly, a person who worked 40 hours could also be burned out. So creating these sort of difficulties with respect to measurement and the outcome. And we thought it was because initially, and we always give this as sort of a caveat for these results, is that it was done with with interns who had very very different at an early stage in their independent practice career. So it might be because of that. Actually, a colleague of mine who worked on a SK with me at Stanford replicated the same code, same study in outpatient physicians at Stanford and found almost exactly the same performance results. And that was just published last month in Mayo Clinic Proceedings. And that also found exactly the same results, which sort of shows that, again, while audit logs are a powerful medium, it only captures EHR-based work, and there's more to burnout than what people are working on the EHR. So again, coming back to this this sort of overarching figure from the National Academy of Medicine with respect to looking at the sort of the high-level systems level view of activities and actions and how we study this, we're still in a very narrow space of looking at audit logs and how to study study a part of the physician behaviors within that. And it's as we showed, it's potentially plausible that there are relationship between the workload and work-related actions in burnout and errors, but predicting them without further context of maybe significant individual level factors is probably slightly far away in terms of these models. So I'll wrap up quickly. So what's next? We've done a lot of work, especially recently, trying to look at how can we use these sort of audit log events and sort of modeling techniques in order to identify what people are doing at a higher level. Because these action sequences are at like a click level or even lower, can we combine them in sort of automated fashions? And we've started to do that. It's and the sort of short answer at this point, it's still an evolving piece of work. When we first did this, we didn't have large language models publicly available to train this. We now have trained, I want to say 20 billion rows into a large language model of what I would call a grammatical model of action. And then hopefully we'll have some stuff that's coming out in the near future, which is looking at like how can you structure, what can we say about people's tasks and how they work. I have a NLM R1 with Julie Adler-Milstein, which is basically looking at the effect of telemedicine. This was done, this proposal was submitted during COVID. We were trying to compare what are the differences in work settings in terms of work activities between telemedicine and face-to-face, and how does it affect sort of outcomes. This is still ongoing work. We found significant differences between people who work in telemedicine versus not in terms of total time, how much time outside of work, time spent on messaging, the workflow patterns. So that paper also should be coming out pretty soon. So that's still ongoing work. I talked briefly about where else we can use this. So we did this study last year. Can we use these sort of EHR-based work activities to measure reimbursement? Meaning that, are you getting paid for how much work you did? So I'm in anesthesia, so we started looking at anesthesia reimbursement models. It's the good thing about anesthesia is that it's got a very structured reimbursement model. And we ran this study, and I'll get to what we did, but essentially the anesthesia reimbursements based on how much time you spend in the OR from anesthesia start to anesthesia end, with some additional money for additional reimbursement for procedural complexity and things like that. So essentially, we try to compare for every case in, I want to say about 30,000 cases. We try to compare whether the billed units was comparable to sort of the total clicks that happened during the same period of time. And what we found was that people, the anesthesia clinicians are undercompensated for their patient complexity, meaning that if the patient's more complex, which actually makes sense, because if the patient's more complex, the anesthesiologist has to dig in more in terms of finding out all the factors related to those actions, and and it takes more effort on the EHR in terms of work. So this was recently published, JAMA Network Open. We have some follow-up studies with this with a much larger sample. Again, anesthesia billing uses very arcane policies, so it's very hard to change. It's lots of bundled payment mechanisms. Also, there's lots of exciting stuff that we've sort of branched out. We're trying to look at audit log events with known healthcare processes. One of the things that we've done is to look at SecureChat. SecureChat, and there's an equivalent version in Cerner. I forget what it's called. SecureChat's the EHR integrated version of Teams for the EHR. Essentially, you can send messages, and if you want to look at the average number of messages, it's at WashU BJC, it's about close to 2 million messages a month across both inpatient and outpatient. So again, the advantage of this using audit logs is it's an easy way to capture this. The disadvantage is that they're expanding at such a scale, we don't have a full context of what's going on. Again, the volume of those messages is what I wanted to highlight here. We just published our first paper on looking at the messaging use patterns with, I want to say, about 10 million messages. And this, I know there's lots of groups across the nation working on it. But with audit logs, what we have the potential advantage is that can we look at things like our secure messages interruptive. So for example, the message read latency is about 29 seconds. The median response rate's about 29 seconds, showing we have the opportunity, the first, I want to say, opportunity to directly and potentially objectively measure interruptions and potentially look at the effect of interruptions on downstream activities. And I'm not going to present that here, but we looked at with 2 studies that are almost ready to go out. So one of which looked at does the volume of secure messages affect the total EHR time? And the answer is yes. And does the volume of secure messaging increase patient switching, meaning increase the cognitive load? The answer is yes. And does the volume of secure messaging increase wrong patient errors? The answer is also yes, by a factor of about 20%, by odds of about 25%. So again, we started, this is one of those, these are studies where we combined both the metadata from the secure messaging and combined it with audit logs to measure all of those other metrics related to work practices and trying to combine and study sort of behavioral outcomes related to it. So again, I want to end with where is this going? Till about a year ago, we were still with single center studies with audit logs, primarily because this is large volumes of data. And IRBs are generally loath at exchanging such big volumes. So the scope and scale of these studies need to change. Our HRQ study uses 3 sites, Stanford and University of Colorado, and we're building a repository, a de-identified repository, which actually took more effort than anything. It's for the last 1 year, we've been building a pipelines for de-identification of like billion rows of audit logs. So that these studies need to be conducted multi-site or pan CTSA type of studies, and to show value, right? So potential for data model. There are no data models in this. This is fairly simplistic. What are the potential for data models in building this? There's also, we have a small community between Julia, me, and there's a couple of other smaller groups that were creating these large repositories and code bases that people can, freely use. We have a Git repository, and what we need is potentially a larger collaborative enterprise for building this sort of work. So I'll stop there. Thank you for the opportunity to present. Happy to answer any questions. My emails also. Again, I just want to thank all the folks that have helped me, especially Sunny Liu, whose slides I've adapted for this talk. She was formerly my postdoc, now faculty at WashU. She did some exciting work. Most of the work that I talked about on SecureChat's her. Lots of other students. My email's down there. Free to contact me. Happy to answer any questions. Thank you very much.
Yeah, thanks. Thanks very much. There's a question. Jim has a question. What about looking at caseload, number of unique patients viewed as a proxy?
Yes, we actually looked at both. So caseload was so we looked at number of patients on a per day, because all of our analysis was done at a per day basis, we looked at number of patients access per day as a covariate in all the models. We also looked at number of notes signed, which is number of patients touched sometimes can be messy. So we looked the number of notes signed as a proxy for that you actually cared for a patient.
Thanks. There's another question. Audit log is powerful resource. One can compare pandemic period to the pre-post pandemic period to see the workload changes. That's always an interesting thing, like, because that was such a big disruption that I wonder what happened during that time. And there wasn't burnout, but then there were other places like units that closed and didn't see patients.
Exactly. So it's very tricky to yes, definitely agree that the workload changes during COVID, but there were our NLM studies actually looking at, we've selected 3 periods, but what we're finding now is that there were so many disruptions and so many changes, right? Like, what is telemedicine? What was telemedicine changed from the beginning, like, July of 2020 through 2021, like, Zoom and versions of other third-party apps, and how the workflow changed. So the COVID period is yes, it is worth looking at, but there's so many unmeasured covariates that's harder to explain.
Just a couple comments about what a great talk. And unfortunately, the folks in the room there had some technical difficulties, so it was harder for them to fully participate. But we were able to chat. Another comment about a great talk. I'm wondering, are there other things that you can look at in terms of effect, other things besides wrong patient errors? It's nice to have that. That's a very, that can be compared. If you look at the same thing, you have a very exact definition of that. I wonder if there's other things you can look at as impact.
I would say the reason why we started looking at wrong patient errors and others have started to look at it is purely a matter of convenience, right? Again, there's no overhead in order to measure it. Like, we have a query, happy to share it. Like, we can run it in Cerner, Epic, whatever. It's measurable, it's available. The huge disadvantage is it's only one type of error. It's also a self-intercepted medication error. There's lots of errors that are never caught. So it's a very narrow definition of what an error is, but it's pragmatically easily captured, and that's the only reason. We've started to look at pharmacists reported errors too. In Epic, there is pharmacists when in inpatient, when they identify some of these errors, create what's called IVENs, which is essentially a report and asking physicians to change the order. So that we've started to use it. Again, it's not as reliable and objective as wrong patient errors. I agree. I mean, if there are better algorithmic ways, if there are alternative algorithmic ways to capture other types of errors, like wrong dose, wrong drug, wrong incorrect strength dose route, whatever that is, right? Like, so if we can capture some of those, we can do it. We also started to think about like reported errors, and what we found is that the actual reported errors are like less than 0.01%, right? Like, in general, only the very serious ones are actually reported through the appropriate channels, right? Like, so it is challenging. So I wish there were others there, but at the moment we're stuck with these sort of fairly easily available measures, and I will agree that it's a matter of convenience only.
Well, if it works, and it's definitely kind of the thing you want to prevent, and because you're also looking more at the factors that contribute to that. It's a measure of that. There is a comment which actually of interest to me too. Is the raw audit log in Cerner readily available like it is in Epic? I've played.
And the answer is yes.
Yep.
The answer is yes. I just don't have the. Since I don't work with Cerner, I just don't have the queries to pull it. Yes, it is.
Yeah, they do have the dashboards, and I've looked at that too. It's kind of clunky, and you end up with a lot of raw data, and it may be hard to get the meaningful things you want from it. Like you mentioned that earlier. I just have a comment that I'm glad that there's a lot of attention being focused on this. Like when you showed that the Institute of Medicine, I think it was, that they had that report, the systems approach to burnout. And it had all the different factors, individual, environment, and everything. I was glad to see that this is getting so much attention, because I just remember just a few years ago, it was just like, oh, burnout. Okay, well, resilience training. And that was the only.
Yeah, do yoga.
Yeah, that's right. It's like, it's insulting, really, but glad to see that. And that I wonder if it's possible to also look at some of those metrics to identify who's at risk. And so someone could say, oh, maybe we need to address that physician's workload or something, you know, that
Right.
instead of just suck it up, just do your job kind of thing.
Right. So our goal with the burnout study, even though preliminary, was essentially that. Can you screen people for potential burnout based on workload? And I think the general answer is no, because there's too many other things that contribute to it, right? Like their colleagues, what's happening at home. None of that you can measure based on just workload alone. Do you know what I mean?
Yeah, that's
And
true. It fluctuates too.
Yeah, and it is burnout is multifactorial, and when you look at this one aspect, which is an important aspect, and I'm not trying to reduce the importance of that workload aspect, but it's only one aspect of maybe 3 or 4 equally important aspects that potentially contribute to it, right? Like, so it is complicated, but I do agree that I strongly believe that audit logs now are sort of mainstream now. When I started working on it 4 years ago, it wasn't. It is mainstream now. More people are working on it. We'll see more sort of ideas generated and more focused work. Till now, I want to say till about 2 years ago, 90% of the published papers were, you know, summary stats and aggregation, right? Looking at outcomes from this has been very, 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 very limited. So it's going to expand. It will improve. There's lots of other political things going on in the background, one of which is that, for example, I know Epic only really well, but Epic does not want you to use the audit events for any of these, right? Like they have their own framework and that they want to use for measuring work-related activities. But lots of people are using audit logs. Their measurement is their proprietary measurement. They won't tell you why or how or what decisions they make. So there's a separate database that's called UAL, user activity logs, which they want to use. We don't use that. But so there's all sorts of things going on. I just want to say one other thing about Cerner. Nate Apathy, who was at Georgetown MedStar, is the person who's worked with Cerner's access logs, and I'm happy to make connection. He just moved to University of Maryland, but I'm sure he's the one who I know knows the Cerner access logs really well.
Yeah, that'd be great if you could share that info. Could do it by email afterwards. And
yep, happy to do that.
Unfortunately, we're over time, and even though this is a great discussion and such an important topic, but thank you so much for speaking for us, and it's a great presentation, and continue to do this important work. I'm glad to see your work's getting funded, because it seemed like the pendulum has finally swung back to clinical informatics, whereas before it is like bioinformatics is the place to be. But
it is definitely changing, and I'm glad it is. But you know, this sort of stuff would never have gotten funded, I want to say 5 years ago.
Yep. All right, well, have a great weekend, everybody. And we don't have a power talk next week, so don't join next week, but then the week after that we do. All right, take care, everyone. Have a good weekend, and happy Year of the Dragon. Bye-bye.